All right. Good morning, everybody. Welcome to Pediatric Grand Rounds here at Seattle Children's Hospital. I'm Suzanne Mazer. I'm Director of Continuing Medical Education here at Seattle Children's. So thank you so much for being here. And with that, I will introduce our speaker, Dr. Margaret or Meg Fisher. She's a world-renowned pediatric infectious disease consultant. She's a professor of pediatrics and infectious disease and the medical director of clinical and academic excellence at Monmouth Medical Center. Besides being a sought-after speaker all over the country, her work includes chapters in Nelson's Book of Pediatrics, work on the Committee of Infectious Disease, and a chapter on infection control and prophylaxis in the AAP Red Book. Thank you so much for being here. And with that, I will say welcome and take it away, Dr. Fisher.
Oh, thank you so much. And it's a pleasure for me to be there. I would certainly love to see Seattle in person. But it is a lot shorter commute for me to give you this talk from New Jersey. So what we're going to talk about today is pets as pests. Now, whenever I do that, whenever I talk, I have to give my disclosures. And let me say that I have no disclosures. I may mention off-label uses of drugs, and if I do that, I will remember to tell you. The other thing I wanted to mention is that the images in this on these slides are either taken from the Centers for Disease Control or from my personal photos. And I've tried to include references for you through the talk. So this is my disclaimer. So talking about pets as pests, might offend some people, but I show you this picture to show you that in my family, there's a dog and a cat, as well as a young boy who is now actually a teenager. So that's my disclaimer. So what are the objectives? What I want you to get out of this talk? Well, by the time we're done, I want you to be able to manage a child who's been bitten by their pet or another pet, counsel a family regarding which pet that they might consider selecting for their child, and counsel a pregnant woman about precautions that she may need to take around pets. So pets and children, I mean, they really share the space very closely. And you can see those dog tongues and those dog mouths are right up close and personal. And they share lots of things with the children who are in their spaces. So we're going to talk about some of the benefits and risks of pet interactions. So why should we even have a topic like this? Why worry about this? Well, the fact is that more than half of families keep pets. And if I were in the auditorium talking to you right now, what I would ask is for everyone who has a pet to raise your hand. And what you would see is that probably more than half the audience, it's a group of pediatricians, so probably 80% of the audience would have their hands up because they have at least one pet. Then I usually say how many people have 2, 3, 4, 5, 6. So I'm going to invite you in the chat, if you think you're the person with the most animals, put in the chat how many pets now these are pets, not if you're on a farm, I'm not interested in that. But how many pets do you have in your home, and we'll see who the winner is. So there are over 130 million pets in the United States. And the variety of species of animals that are kept as pets has really been increasing and has become somewhat concerning because of the illnesses you can get from some of these exotic pets. And I have a question in the chat, do fish count? Of course fish count, they're pets. So, and nobody's really taking me up on my how many pets do you have, but maybe as we go on, you'll get more into it. I want to give you two excellent resources for pet associated illnesses, and that's the Centers for Disease Control and Prevention, cdc.gov. And if you just go to their Healthy Pets website, you will get all the information that you would like on a whole variety of topics. The other thing you should know about is the One Health Initiative, which is a collaboration between the CDC and the veterinarian group. And it really is all about ensuring that we make the earth safe for not only ourselves, but also for our animals. So what are the pros of having a pet? Is there really anything that pets really give you? Well, they certainly provide love and comfort and company. We know that from several studies that people who have pets, it does decrease your stress level. There's some evidence it decreases your blood pressure. It makes you more active because you tend to have to go walk the animal or at least get up and play with them. So it really does tend to do lots of things that are very positive. I once heard, or I've heard parents say, well, we got a pet because we want to teach our children responsibility. I'm not sure that really works so well, but I think it generally teaches responsibility to the parents, which probably they didn't need to be taught anyway. So think about these other things that pets definitely do that are helpful. Well, what about the cons? Well, we know that pets can cause trauma to children. We know that many children will have allergic reactions to pets. And then what we're going to talk about today are the infections that can be related to pets. So let's start with some cases. So the first case is a 2-month-old boy infant who presented with diarrhea, fever, lethargy, and a generalized seizure. On his physical examination, he had a bulging fontanelle and he was unresponsive. He also had heme-positive stool. He had his spinal fluid examined, and the spinal fluid gram stain was positive for gram-negative rods. So what organisms are likely? And here, if you like, you can answer in the chat, or I'm going to give you a little time to just think about it, because many of you have probably already thought about what the answer might be. But while you're thinking about it, I'm going to give you a little extra history. And, you know, we always teach the residents that history can be our friend. Sometimes it's misleading, but in this case, it was very interesting that the father of this infant had just started a business where he was farming turtles. So he had a number of turtles within the household. So with that as a hint, does everybody know what this is going to be? So there are lots of bacterial pathogens that are associated with pets. And the one that comes to mind here, the one that can cause meningitis, is of course Salmonella. So let's talk a little bit about Salmonella. Salmonella are gram-negative enteric bacilli. They are associated with a whole variety of pets. The ones that are best known are reptiles. These, funny new trends in pets are these iguanas. But they're also the reptiles or the snakes are heavily colonized with Salmonella. And there was even an outbreak in the Southwest of Salmonella related to people who were ingesting rattlesnake capsules. And these are thought to have health benefits. I'm not sure that they do. In this case, they certainly didn't, because the rattlesnake capsules were full of Salmonella. Turtles, of course, are and have always been a source of Salmonella. And, you know, you think of this turtle when it has Salmonella and is crawling around on it with its shell kind of dragging, it's just leaving that nice thin layer of Salmonella for a person to come around and pick up. And here, this lizard, you know, he's leaving a little Salmonella on that hand that certainly allows for easy transmission of this organism. Remember, of course, Salmonella is often foodborne as well. Chicken and eggs are some of the biggest culprits, turkeys as well. It's said that about 50% of chicken carcasses in the supermarket will have Salmonella in them, and about 1 in every 10,000 eggs. So there are lots of ways that you can get Salmonella, but since we're talking about pets, in this case, and in this unfortunate child with Salmonella meningitis, it really was related to turtles and a turtle farm that was in her home. The usual diseases caused by non-type brutal salmonella are febrile illness, generally with gastroenteritis, not always bloody diarrhea. About 50% of the time it's bloody, about 50% of the time it's not. Unfortunately, many people with salmonella gastroenteritis may get a bacteremia, about 5% overall, and sometimes higher numbers than that are reported for infants. And that bacteremia may result in a focal infection. Urinary tract infection is probably most common, but you can also go to bones, to brain, to lungs, and to just about any place in the body. Salmonella has a very short incubation period. It's just 6 to 48 hours. And when it causes gastroenteritis, the hallmark of that is that it's really foul-smelling diarrhea. So salmonella makes hydrogen sulfide, and so the diarrhea really smells like rotten eggs. In addition to that, it frequently is greenish in color. So green rotten egg smell, think salmonella. Crampy abdominal pain is also common. And as I mentioned, the extraintestinal sites are the blood, the urine, the central nervous system, and bone are the primary ones, but it can get elsewhere. You make the diagnosis by culturing the stool or the body fluid. And if you have gastroenteritis, the therapy is just supportive. Antibiotics do not shorten the course of the gastroenteritis and may increase your risk for symptomatic relapse. Of course, if you have extraintestinal infection, if the organism's in the blood, the urine, or the brain, or surrounding the brain, then antibiotics would be appropriate. The antibiotic you would start with for a systemic illness would be a third-generation cephalosporin, and then you could, depending on the susceptibilities, you might alter your therapy. So how do we prevent salmonella? Well, the major thing here, as with lots of things in infection control, are good hand hygiene after contact with your pets. So be sure to remind any of your families when you talk about pets, make sure that they are doing the good hand hygiene following contact. Of course, the kind of contact we have with our pets, and we're not always washing our hands, you can understand how the organism does get from the pet to the people. For immunocompromised patients, they really should not have pets, such as turtles or amphibians or snakes. And for children with hemoglobinopathies, of course, we worry about salmonella osteomyelitis. So again, I would tell them that for the child with sickle cell disease, it is not a good idea to have a pet iguana or turtles or many of the other reptiles that can carry salmonella or that do carry salmonella. Okay, let's go to the next case. So this is now a 6-year-old girl, and she comes to you with her second bout of bloody diarrhea. So her 3 older siblings and her parents have been entirely well. None of her friends are sick. But just by the by, this new little puppy, the puppy has diarrhea as well. Now, in this case, which organisms comes to mind? I'm checking the chat box here, and I think we have a tie between 9 dogs and several cats, but that's not really the person, that's the vendor. And then we have someone who actually has a dog, a salamander, a frog, and a bunch of fish. So I'm going to give Pat Berry the credit for most pets or most unique pets. And that salamander is a salmonella risk. So now I see in the chat box, Campy comes to mind, and indeed, that's exactly what should come to mind, Campylobacter. The Campylobacter, there's Campylobacter jejuni, Campylobacter coli, and Campylobacter infantis. And these are all causes of gastroenteritis. There are motile, comma-shaped, gram-negative rods, and the pets that are involved here are primarily puppies and kittens, but also hamsters, and the little chicks that you sometimes get at Easter time. And then these also are foodborne, and these are mainly chickens and turkeys. And again, about half of the carcasses in your food store, if you cultured them, you would recover Campylobacter or Salmonella. And turkeys, about the same, probably 80% for the turkeys. Now, Campylobacter generally causes just plain old gastroenteritis and abdominal pain, and fever is variable. But of course, the extraintestinal thing that goes with Campylobacter is Guillain-Barré syndrome, and that's because on the surface of these organisms, there is an antigen that cross-reacts with myelin. So an interesting post-infectious complication. I'm actually still looking for my first case, but even in a lifetime in infectious disease, you don't see all that many cases of Guillain-Barré in children. So how do you make the diagnosis of Campylobacter? Well, the way that you would make the diagnosis is to, first of all, think of it and then culture the stool. And what about therapy? Well, in this case, if you talk to an ID person or you talk to a gastroenterologist, you might get different advice. Therapy should always be supportive, and an ID person will tell you that macrolides both shorten the course of the disease and can eliminate carriage so you don't get those relapses. The gastroenterologist will say, hey, the major side effect of macrolides is abdominal pain and crampy diarrhea. So why are you giving a drug to treat an illness that has exactly those symptoms? Plus, generally, by the time you figure out it's Campylobacter, the patient is already better. In that scenario, I think you could argue maybe you don't need macrolides, but it's actually a single dose of azithromycin will get rid of carriage and decrease that chance of recurrence. Campylobacter gastroenteritis is something you ought to think about in the teenager who looks like they have inflammatory bowel disease because of that relapsing diarrhea. So, of course, all gastroenterologists will look for stool pathogens before they make the diagnosis of inflammatory bowel disease. And again, hand hygiene is going to be the most important thing in prevention. So let's go to the third case. The third case is a 13-year-old girl who developed unilateral conjunctivitis on New Year's Day. It's now the middle of January, and the conjunctiva is still inflamed. It's just looks kind of like that. On physical exam, in addition to the conjunctivitis, you notice that there's a preauricular node. So this could be described as Perinald syndrome. So conjunctivitis and preauricular node and unilateral. So the question here is, what pet did she get for Christmas? I'll give you a second to think about that. Maybe throw it in the chat if you want. Okay. We have one person going for a rabbit, but this one was actually cat scratch disease. So this is Bartonella henselae, and the conjunctiva is the entry site. So instead of that inoculation papule, you have that conjunctival injection, and the draining lymph node is the regional lymph node is the Perinald syndrome, the preauricular adenopathy. So cat scratch is a really neat disease. So we now know it's caused by Bartonella henselae. Actually, the first organism isolated in a case of cat scratch was Aphipia felis, but it turned out that that's an unusual cause of cat scratch. But I love the name, Aphipia for the Armed Forces Institute of Pathology and felis for the cat. But Bartonella henselae is what is going to be the major and really all that you're going to see is the cause of cat scratch disease. And with the cats have asymptomatic bacteremia with this organism. And it's actually spread from cat to cat by fleas. And kittens are highly susceptible to get it. They actually can get it very close to the time of birth. And the kittens are the ones that are very likely to be scratching people. So that's what you're thinking about. You're thinking about the kittens. Interestingly enough, the fleas that transmit this from cat to cat really stay on the cats and don't. There's not evidence that the fleas are biting us and giving us Bartonella in that way. So this is a picture from the CDC website of that inoculation papule. You can see it's rather subtle, but these are definitely worth looking for. So if you see a patient with regional adenopathy, ask about cats and look to see if you can find that inoculation papule. So the other symptoms that you see with cat scratch disease are fever, malaise, and adenopathy. And these nodes suppurate in about 20 to 30%, or those are the numbers that are given. I think that may be an overcall. Many people probably have the adenopathy, it goes away, and they never even get diagnosed. There's a very weird thing with cat scratch disease. Some people will get an encephalopathy, and this may be several weeks after the after the lymph node appears. And those patients present with a seizure, and then they are comatose. They are out. And a couple days later, without any specific management, they will wake up and they'll say, hey, what happened? And in general, they will be perfectly fine after that. No additional therapy is needed. So a very unusual encephalopathy linked to Bartonella henselae. The other thing that's become known over the last 10 years is that cat scratch disease is a very common cause of fever of unknown origin in children. And often there are splenic lesions. So if you do an ultrasound of the abdomen, you may see lesions in the spleen, but those are not always present. But it is is something that you should think about in the patient with an FUO. So the diagnosis is generally a clinical diagnosis. You can use serology to try to confirm the diagnosis, but there is some trouble with cross-reacting positives. Pathology, if the node is removed because of other concerns, there is a fairly classic granulomatous necrotic granuloma kind of formation that many pathologists will say, yes, this looks like cat scratch. And then there used to be a skin test, but this is no longer used. The skin test was actually a lymph node that was kind of ground up, smashed up, and then that lymph node was injected into other people to see if you got a positive test. Needless to say, we no longer make skin tests out of other people's lymph nodes, and it wouldn't be really safe to do that. So the skin test has gone by the wayside, but the serology is useful, and there is also a PCR test that can be done directly on the lymph node. The therapy here is really supportive. The vast majority of these people will get better even if you do nothing. There is one study that showed that azithromycin did make the nodes get smaller a little bit more quickly, but many infectious disease doctors are not all that thrilled with that study. There are a whole variety of other antibiotics that are active against Bartonella in the laboratory. And if I had a patient with fever of unknown origin, I probably would give systemic therapy. I might use the gentamicin or the quinolones. As far as prevention goes, you just have to prevent getting scratched by a cat. And if there's a cat in your household, that may not be the most practical thing. Okay, let's go to case 4. So case 4 is a 15-year-old girl who develops cough and fever. You ask additional history, and you find out that the family cat just died. And the big hint here is the whole family lives in the Southwest. So maybe they came to Seattle for whatever, and the child developed this illness, but they live in the Southwest, and their cat lived with them in the Southwest, and the cat has recently died. So what's the diagnosis here? All right, giving a chance for anybody to throw a guess in the chat. Okay, no takers. So this is actually Yersinia pestis or plague. So Yersinia pestis is a pleomorphic gram-negative cocobacillus, and it has a rodent reservoir, rodents and squirrels. And that reservoir for this organism is mainly in the southwest of the United States, so New Mexico, Arizona area. And within nature, the rodents and the squirrels kind of pass the organism back and forth among each other. And then occasionally one of those household pets will get involved. So it's transmitted back and forth by fleas. So the pet can be involved either by picking up one of the fleas from these animals, and then the flea may inadvertently bite a person, and absolutely these fleas do bite people, or the cat can get it by actually killing one of the rodents, and then the cat inhales the organism. So in this case, the cat actually died of plague pneumonia. And as many of you who have cats may know, cats love to sleep on top of people. And when a cat's sick, many children or adult pet owners will actually sleep with the cat right on their chest. If the cat has plague pneumonia, then they can transmit that to the owners. And there have actually been a few cases of this in Southwest US. So the humans can either be bitten by the fleas or exposed to the ill animals. There's an incubation period of about 2 to 8 days. And then what happens to the people? Well, in bubonic plague, it's fever and swollen lymph nodes. So that was the bubonic plague. And the swollen lymph nodes are called buboes. So that's how it got the name. In the septicemic plague, there's hypotension and septic shock. In pneumonic plague, there's cough, fever, dyspnea, hemoptysis, and pneumonia. So how do you make the diagnosis of plague? Well, you can try to culture the organism, but remember, you really need to let your lab know that that's what you're looking for, because they need to be very careful that it's not transmitted within the laboratory. Serology also works, and of course, there's a PCR test for this as well. Treatment here is gentamicin or doxycycline or a quinolone. Okay. Let's go on to the next case. All right, now we got a few people in the chat here. But remember, everything's got to be pet-borne. So that's why coccidioidiomycosis and valley fever won't work, because there aren't pets involved. And yes, many people do get a broken heart from loss of the cat. So case five is an 11-year-old boy who was bitten by his friend's dog. And they call your office to ask what should they do. So in the chat for me, or let me know, what do you think? What is it that you want to know, and what are you going to advise this 11-year-old boy? Let's think about that for a minute. So as we think about what we want to know, exactly, we want to know, are the vaccines up to date? So we want to know two things. Has the boy been vaccinated, and has the dog been vaccinated? We also want to know much more about the bite itself. Which body parts involved? Is this a bite of a hand in which you may be very concerned? Or is this a bite of an arm, and it's a mild bite and it's not very exciting? And then absolutely you want to know, was this bite provoked or not provoked? The chances of an 11-year-old boy messing around with a dog, likely it was provoked, even if the person didn't need it. But yeah, there might be a situation where it's a totally unprovoked attack, and you definitely would want to know about that. As far as what do you advise, let's talk about animal bites and how we manage them. So animal bites are extremely common. And as you know, most animal bites are either from your own pet, or from a relative's pet, or from a friend's pet. So they usually aren't random stray animals out there biting people. They most often are from the family pet. The organisms we think about are either the organisms in the mouth of the pet, okay, or the organisms on the skin of the child. So the major mouth organism that gets people in trouble from pets is Pasteurella multocida, or multicida. People pronounce it different ways. Also, the oral anaerobes of the dog or cat can be involved in these infections. And then, what was on the child's skin? Is the child a carrier of Staph aureus or group A strep, in which case those organisms can be inoculated into the soft tissues by the bite. Now, it also matters, what kind of animal is biting, because cats tend to have much smaller teeth and very sharp teeth, so they may penetrate. And if it's on a hand, they may actually penetrate into a joint. On the other hand, the thing you worry about with dogs, and particularly big dogs, German Shepherds, Rottweilers, is, is the strength of those jaws. So that sometimes there can be a lot of tissue trauma due to the bite. Again, if it's an extremity like a hand, they can really do some considerable damage, and there can be crush injury, and then you may have to worry about compartment syndrome. But as far as the infections that you're going to get from the bites, generally you're going to see cellulitis, and the speed of the cellulitis can give you a clue. If you see cellulitis within 24 hours, that's going to either be Pasteurella or Group A strep. If you see cellulitis a week later, that's the one that's likely to be Staph aureus or the anaerobes or a combination. So very short incubation with both Group A strep and Pasteurella, longer for Staph aureus. You may also see lymph node involvement, and depending on whether the tooth actually got into the bone, you can see osteomyelitis or joint infection if the tooth got into the joint space. Diagnosis is a clinical diagnosis, and if something looks like it's infected, I would definitely try to culture whatever drainage you have. I wouldn't culture a wound right away to see what you might grow there, because in fact, if you really clean the wound well and take care of it, even if you grow a pathogen, it may be an innocent bystander. So what's the therapy? The major therapy here is clean the wound vigorously. And that's the advice you're going to give over the phone. And most times you're still going to want to see the patient, because you want to really take a look at that bite and see, what happened, what soft tissues or bones or joints might have been involved. You're also going to think about whether you need tetanus or rabies prophylaxis. So that depends on the status of the child for tetanus and on the status of the dog for rabies. And we'll go into those. Then there's the question, should the laceration be closed or not? If you don't need to close it, if it's a small laceration, there certainly is no reason to close it. Why would I have tried to avoid closing it? Because when you put sutures in, you dramatically decrease the amount of organisms needed to cause an infection. So leaving the wound open or simply using Steri-strips to close it is much more preferable to having to close it with sutures, and you never want to glue a bite closed. That's really asking for trouble. So don't use tissue glue to close these, and consider trying Steri-strips if it's a small wound. Obviously, if it's a large wound or if it's a wound to an area that's compromised, you may need to close it, and you may even need to explore a lesion on the hand or over a joint. As far as antibiotics go, I would say now most people would give an antibiotic as prophylaxis. If it's a large wound and you can clean it well, you probably don't need it. But if it's especially a puncture wound, those are very difficult to clean out. So it's reasonable to use amoxicillin clavulanate. So the amoxicillin is what you need for the Group A strep and the Pasteurella, and you throw in the clavulanate for the Staph aureus. Now, if you knew that the child was colonized with methicillin-resistant Staph aureus, this combination won't work. In that case, you might have to use trimethoprim sulfa. However, trimethoprim sulfa, the Pasteurella is not going to be susceptible. So there's not an ideal therapy if there's known carriage with methicillin-resistant Staph aureus. As far as prevention goes, it really is important to educate parents and patients about how they approach animals. Never try to take away food from an animal. Never try to take away a puppy from its mother. Those kind of things that are common sense. But as we all know, common sense is all too uncommon. Let's talk about tetanus prophylaxis. So although it's very hard to even read of a case of tetanus following a bite. It almost never occurs, but tetanus prophylaxis is still recommended. And this does give you an opportunity to get people up to date. So if a person has had less than 3 prior doses of tetanus vaccine, then they should get another dose of either TD or Tdap. In the case we were talking about, the 11-year-old had just gotten his Tdap, so he doesn't need to have any additional immunization. And this is just a picture from the CDC of tetanus in a newborn. And this is related to the cord and contamination of the cord, not to a bite. But it shows you that spasm of the muscles, which is what leads to the morbidity in tetanus. Now, what about rabies? So it's relatively unlikely that you're going to get rabies from a dog or a cat in the United States. But that doesn't mean these don't exist, because not everybody remembers to vaccinate their cats. Pretty much everybody vaccinates their dogs, but not everyone vaccinates their cats. And of course, vaccine hesitant families might not vaccinate their dogs. And the dog or the cat can run into one of these wild animals or a bat, and these are the major reservoirs for rabies. So it's coyotes, foxes, bats, skunks, and raccoons are the major reservoirs for rabies. And the vast majority, 90% of the cases of rabies in the United States are related to bats and bat bites. And very few people have bats as pets, so we're not going to talk too much about rabies, except we will talk about rabies prophylaxis. What would you do? So if the child's bite is from a dog, a cat, or a ferret, and the animal's healthy, you can simply observe the animal to make sure that they don't get sick within the next month. If the animal is sick, then rabies prophylaxis is recommended. If it's unknown, you should consult your local health department or local pediatric infectious disease person to ask about what they think the likelihood is that you'll need to have prophylaxis. If it's a wild animal, you should consider the animal rabid, particularly if the child was able to get near the animal, or if it's a nocturnal animal that's around during the day. So a bat that's flying during the daytime, or a skunk that's out during the day, or a raccoon that's out during the day, or a coyote or fox, they should be considered rabid, and children should be taught stay away from wild animals. Unfortunately, if you can get close to a wild animal, the chances are that that animal is very sick. As far as prophylaxis, absolutely that would be indicated with a wild carnivore. For rodents and rabbits, they really do not transmit rabies. Probably the major reason is when they get rabies, they die of the rabies before they can transmit it. So usually prophylaxis is not needed. Remember the way the rabies goes, the bite happens, the rabies is inoculated, it travels up the nerves, goes all the way up to the brain, replicates in the brain, and then gets into the saliva. So for the rodents and the rabbits, the brain infection kills them before the virus gets back into saliva. But that is not true for the other wild carnivores. What is prophylaxis? Well, it's rabies immune globulin and then 4 doses of the rabies vaccine. Okay, let's go to the next case. So the next case, your patient is a healthy 4-year-old boy, and he visits the emergency room after falling. And for some reason, a complete blood count is ordered, and the patient turns out to have a white count of 10,000, but there's 20% eosinophils. So the ED doctor says, all right, I'm going to send him back to his primary physician to work that eosinophilia up. So now you have a 4-year-old, otherwise healthy boy who has an incidental eosinophilia of 20%. So what organisms are you thinking about now? All right, nobody's biting, forgive the pun. All right, so now we have to begin to be thinking about parasites. So eosinophils go with parasitic infections, and the major one you're going to think of here is Toxocara, which are the roundworms of the dog and the cat. There are a variety of other parasites that you can acquire from animals. We're only going to talk about Toxocara and Toxoplasma. They are the easiest to pronounce, and that's what I've decided we'll talk about today. So let's talk about visceral larval migrans. So this is from Toxocara and Toxocara cati and Toxocara canis. And these are the roundworms of the dogs and the cats. And here's the life cycle. So in the feces of the cats and the dogs, they shed the ova. And this ova has to mature in the soil. So if you're picking up fresh stool, you're not going to get infected because these are not going to be infectious. However, if you're in your sandbox playing, or if you're on a playground which has been used by animals and they've defecated in the playground, there are lots and lots of infectious ova that are available for you to pick up as you're playing in the dirt or the sand and put into your own mouth. Now, when you ingest that ova, it gets into your gut, and then it penetrates it turns into a larva and penetrates the gut wall and immediately says, wait a minute, this is not a dog or a cat. I don't know what to do. So it just migrates all over your body and it gets encysted. The vast majority of people who ingest these ova, and lots of people do, just to give you an idea, there was a study that looked at how much dog feces was present in Central Park in New York City, and it was 80 tons of dog manure is removed in a year. So that's a lot of opportunity to get exposed to these things that are also in the dog feces. So, however, and the good news is, the vast majority of people who ingest these and have these little larvae, migrating around, don't ever get sick. Occasionally, there's a flu-like illness of just kind of myalgias, and rarely the larvae ends up going to the retina and causes a lesion that has been in the past mistaken for retinoblastoma, and then the eyes have been enucleated when they don't need to be. The retinal lesion can also damage the retina and cause some visual loss. But again, that's pretty rare. So how do you make the diagnosis of Toxocara? Well, it really is a clinical diagnosis. And the key is eosinophilia more than 10%. Think about parasites. Eosinophilia less than 10%. That can be allergies or a whole bunch of other stuff. It's also interesting that these patients have very, very elevated isohemagglutinin titers, like 1 to 1,000, 1 to 10,000 anti-A and anti-B. However, these are not generally available anymore in the lab, but if you can find a lab that does them, you could do that, or you can do specific serology now. Most of the time, it's not necessary to make a specific diagnosis, but you can do it if you need to. Therapy here is really pretty much supportive unless there are symptoms or it's considered that there's a massive load or for the retinal lesions, in which case you can use mebendazole or albendazole. Okay, and again, this is from the dogs and the cats. All right, let's go to case 7. So case 7, on fetal ultrasound, a baby is found to have hydrocephalus, and the baby is also small for dates. When he's born, he's found to be small and anemic. His eye examination shows chorioretinitis. So what pet might be involved here? So I'm going to speed up a little because I have a couple more cases. So in this case, what you should be thinking is toxoplasmosis, and the pet is clearly going to be a cat. So the cat is the natural host for toxoplasma, and the rest of us get it inadvertently, either by eating undercooked meat where there are encysted organisms, or by directly getting the oocytes from the cat. So almost all cats are infected. They shed the oocyst in the stool. The stool then does have to mature. People touch the stool and they then ingest the organism inadvertently in that way, and they can get toxoplasmosis, or they ingest one of these cysts that are in the meat of the animals, and they can get toxo that way. It can also be bloodborne. So generally what happens, and the fact is, by far, most people who get toxoplasmosis have no symptoms at all and recover completely. It is a cause of a mononucleosis-like syndrome, particularly if you get a heavy inoculum. And unfortunately, it can cause severe illness in compromised hosts. In patients with HIV untreated, encephalitis and brain lesions have occurred. But generally, in the patient who's not compromised, it causes really minimal to no disease. Unfortunately, congenital toxo is a major problem. Although the babies are almost always asymptomatic at birth, they may have hydrocephalus if the cyst is in the brain and leads to hydrocephalus because it blocks the drainage of the ventricles. And many patients will have progressive chorioretinitis and visual loss. So there are many countries that actually in France, they screen all pregnant women for possible toxoplasmosis because if you treat the woman while she's pregnant, she has primary toxo while she's pregnant, and you treat her, you actually can also treat the fetus and dramatically decrease the illness in the baby. So diagnosis is made by serology, which is very tricky, or occasionally by histology. If you're not pregnant and you're not immunocompromised, then no antibiotics are really needed. However, if you're a compromised host or you have congenital disease, then a combination of pyrimethamine and sulfadiazine is used, or that can be alternated with clindamycin. The prevention for this is relatively easy. Avoid the kitty litter and gardening and things that might put you in contact with cat feces, and cook meats thoroughly, and don't taste the raw meats to check on your seasoning. So that's a way to limit the infection. And pregnant women should definitely be advised to have someone else change the kitty litter, and don't taste the undercooked meat, and cook the meats completely. So let's go to case 8. So case 8 is a teenager who calls to tell you that he thinks he's got a tick on his leg. And here's his leg, and there's the tick. So what should he do? Well, I think this one's fairly obvious. We want him to take that tick off. But the question, and why do we want him to take it off? Well, you know, there are soft ticks and hard ticks. The Ixodes ticks are the hard ticks. The soft ticks are the Argazidae. I am just blocking on the pronunciation there. And remember, the ticks can serve as vectors, as reservoirs for diseases, and tick bites are just aesthetically unpleasing. I mean, the idea that this tick is attached to you and sucking your blood is reason enough to want to get it off. So how should you remove the tick? Well, you'll hear lots of people's advice on how to remove these ticks. One is to use a hot match, and you take that match and you touch it to the tick, and I don't know what makes people think that's going to be helpful. The problem with the hot match is generally you burn the child or the pet that you're trying to take the tick off of, and if you do heat up the tick, that's not a good thing, because then the tick's going to either vomit or salivate, and that's going to increase the risk that they're transmitting whatever pathogens they may have to the person. You could also use alcohol. Now, if you use alcohol and a tick, you'll just have a clean tick. Nothing else will happen. Some people have used petroleum jelly with the idea that maybe you can smother the tick. Well, that doesn't work very well because ticks breathe about once every 10, 12, 15 hours. So you can't smother them. Fingernail polish, again, thinking that maybe you'll smother them or paralyze them, but that's not going to help you much because then they can't get out even if they want to. So what does the CDC recommend you do? This is straight from their website. You grab the tick as close as you can to the skin and get that head in your grasp and simply pull it out. Now, the big question is, what if it comes out less than intact? So what if a little piece of the head is left in the skin? My advice to you is leave that alone. Don't try to dig out the head. You'll do more damage than good. So let's go to the last case. So the last case is a friend calls you and asks you for advice regarding acquiring a pet for his child. So here's the possibilities. First case, his child is 3 months old. So what do we think about that? Well, that 3-month-old could care less about a pet. So this guy, your friend, is not getting this pet for the 3-month-old. He's getting the pet for himself. So, you have to consider the developmental age of the child and whether it makes sense to get a pet. So 3-month-old, that's not the ideal age for pets. How about a 6-year-old girl? Well, depending on the 6-year-old girl and whether or not she has any underlying conditions, any pet may be just fine. But again, if this is a child with sickle cell disease or if this is a child with thalassemia, then you're going to want to avoid things like turtles, snakes, amphibians, frogs, etc. What about the 10-year-old with leukemia? Can he have a pet? Well, in this case, I think the best advice you can give him is to talk to your hematologist or your oncologist. Because while it may be perfectly fine for this child to get a pet, you don't want to be giving them different information than the oncologist is giving them, because all they want to hear is that it's okay. And if you say something different than the oncologist, that's only going to make for trouble. So in selecting a pet, what are the things we really need to remember? First of all, exotic animals like prairie dogs, the cause of monkeypox, are generally not ideal pets. Wild animals should never be kept as pets. They're meant to be in the wild. Reptiles, turtles, snakes, they all carry the risk for salmonella. We have to think about the child's developmental level. Is this child going to be able to care for the pet and handle the pet appropriately? Or is this child going to do things to the pet that are going to result in trauma to the child? And then finally, is the child immunocompromised? So there are different risks. And maybe is this a child who ought to have a fishbowl or a pet that's a stuffed animal instead of the pet? But they really are not the same as the pets that you can cuddle and love. So that is actually the end of my talk. I've tried to leave a little bit of time for questions. So I'll open it now to the audience for questions.
Thank you so much. We have about 5 minutes for questions. So go ahead and type your questions now. There was a question earlier in the presentation about eosinophilia. And the question is, do pinworms lead to eosinophilia? If you know.
Excellent. So that one I can easily answer. No, pinworms do not lead to eosinophilia. And the reason is they don't have a tissue phase. So the only parasites that will give you eosinophilia are the ones that aren't lumen dwellers. They have to have a tissue phase. So Ascaris, hookworms, the ones that go through tissues before they get to the gut, those are the ones that are going to give you eosinophilia. But pinworms do their entire life cycle within the gut. Amoeba don't cause eosinophilia, so amoebic amniobiasis doesn't give you eosinophilia. So tissue phase is what you need to think about.
Thank you. And if anyone else has questions, you can feel free to either unmute or type away. And in the meantime, I'll just say thank you so much, Dr. Fisher, for being with us today. And that was such great clinical information for all of our clinical practices, and some things that I have to remember to ask about and think about when I'm taking care of patients in the ER. And a question from Esther Chung. Meg, always great to learn from your expertise and wisdom. This is so nice. If we were together in person, you would have heard me laugh aloud a couple times. Thank you. Same here.
Thanks, Esther, I missed you. We missed you on the East Coast. But Seattle is lucky to have you.
Thank you. That's so nice. And from Brian Carton, thank you so much. Very relevant presentation. Totally agree. Also, Tony Woodward says hello. He remembers you from his time back on the East Coast.
And
And
I
then a
certainly
question,
remember Tony. I didn't remember that
he's
he
my
had
boss.
ended up in Washington.
Yep. Any specific risks with ferrets? Question from Sarah Drescher.
Ferrets have fairly, tiny teeth and sharp teeth, so there is the risk for bites. But otherwise, ferrets, despite their kind of odd look, really are not transmitters of much of anything. So you're good. You're okay with ferrets.
Good to know. Start your ferret shopping, everyone. Do they have the same kind of mouth bacteria as dogs and cats?
I have not seen a study that looks at exactly that, and I don't know if they have Pasteurella or not. So that'd be an interesting question.
That can be a fellows
I don't know
project.
the answer there.
Ferret mouth cultures.
There you go, ferret mouth for it.
And a few other people saying thank you so much. A lot of clapping and thank yous from our audience. So we really, really appreciate you. And I'll just give a shout out right now, not only for you, Dr. Fisher, but also for everyone who's recommending speakers to me. This is virtual Grand Rounds has been a little bit of a challenge, but this is one of the great things about it. So if anybody else has a star speaker like Dr. Fisher, please send me an email and give me an introduction. And with that, I see nothing else in the chat, so we'll let Dr. Fisher continue with her day and everyone else as well. Thank you so much for being here. I wish we could give you a big round of applause in person.
Thank you so much,
we'll
and
see you
hopefully I'll
again.
get out to
Thank
Seattle
you.
one day and see you in
Yes,
person.
I can't wait. Thank you so much.
You bet. Bye-bye.
Bye, everybody.